Sequencing of agents in ovarian cancer is a big question. We talk about it all the time. It's been just very hard to study because you really can't, on a clinical trial, you can't dictate what the patient's going to get next necessarily, because it's often individualized to her prior toxicity and schedule. There's so many things that factor into what you pick next. So these studies of trying to sequence what's the optimal sequence we've talked about, but have been hard to do. So you have to take a little bit of almost a pragmatic approach. In a patient who has a BRCA mutation now, they're going to get chemotherapy and they're going to get PARP inhibitor maintenance, and I hope she never recurs. Some of them are going to recur. And if they recur and they're still appropriate for platinum, at this point, they should still get a platinum. And if they recur again, the question will be, what do you use next? Do you use a PARP again? Or do you use bevacizumab? Because she hasn't had bevacizumab yet. And we know from subset analysis again, but we do know from subset analysis from GOG 218, Barbara Norquist did this data, that patients with BRCA mutations don't benefit more from bevacizumab than non-BRCA, but they benefit the same. So you get the same benefit as with everyone else, so why wouldn't you use it? So it's a good drug. So you could use either thing. In a patient who got 2 years of olaparib and didn't recur for 2 more years and recurs again to platinum, why wouldn't you use a PARP again there? If someone who progressed on PARP but then gets platinum and responds again, are you not going to use a PARP? We don't know that yet. So how do you sequence PARP after PARP? We don't know that yet. So there's going to be some guessing. There's studies going on. There's a study called the Oreo trial going on, and there's others coming that are very close to launching that are going to help us answer that question and probably develop some predictive biomarkers, at least for BRCA patients or patients who carry a BRCA mutation, I apologize, to identify those who probably won't respond to PARP again. So that'll be helpful. But until that time, it's going to be a little bit empiric. We're going to be guessing. You know, if I had someone who stopped a PARP and then didn't recur for many years and responds to platinum again, I'm probably going to put her right back on a PARP. In the other scenario, I'm going to weigh PARP versus bevacizumab. In a BRCA wild type patient who's gotten frontline chemo with bevacizumab or frontline chemo with observation, and now she has recurred, eligible for platinum again, it's the same sort of discussion we're having now, where that patient could get bevacizumab, which will optimize her response over chemo alone, and followed by bevacizumab maintenance with a modest but statistically significant overall survival advantage, or they can get chemotherapy and then switch maintenance PARP inhibitor regardless of their biomarker. And this is clinical equipoise right there. So you'll put 10 GYN oncologists in the room and they'll probably give you 5 different variations on what they would do. And I don't think any of them are wrong. I tend to use PARP in that setting only from a very pragmatic standpoint, only because the only way that patient, a BRCA wild type patient right now, can get a PARP inhibitor is in that setting. And if I don't use it in that setting and I assume she's going to be sensitive again in the next line, I'm going to lose probably 40% of my potential patients who could get a PARP because she's not going to be sensitive again. And she can't get a PARP as a single agent as a BRCA wild type at this point. So if you believe that every patient should have the opportunity to see if a PARP is effective for them, then I use it there. You could easily make the argument to start with bevacizumab there. So, you know, that's that choice. That study's never been done, and that choice is one that, again, you have to have with the patient and the physician and sort of what is most important to her. The discussion about whether to use PARP alone is coming. So those studies have been completed and will be presented this year. One of them is Solo 3, which took patients that had 3 lines of therapy and were still platinum sensitive, and randomized them to single agent olaparib versus chemo, which interestingly did not include a platinum. So probably beyond the discussion of this talk, but that's going to be presented this year. And then a study called NRGY004, which is a CTEP, a National Cancer Institute study, took first recurrence, platinum-sensitive patients, and randomized them to chemo, platinum-based chemo versus olaparib or olaparib plus a tyrosine kinase inhibitor called cediranib. And that was, the SOLO3 is only in BRCA patients. This one is all comers. So chemo versus not chemo. And that should result this year as well. We're expecting, I don't know when, but we're expecting that. So that may or may not open up opportunities to replace chemo in certain populations with a PARP inhibitor. Ariel 2 would speak to that, but that was a single arm study, but in a platinum sensitive population used rucaparib with very high response rates and a 9-month duration of response. So it's a nice signal, but single arm, didn't have a comparator. So I don't think you could say that's necessarily the standard of care yet, but it's an option for patients. And we'll see where that kind of fits in. But how you sequence that in when patients have had a PARP inhibitor in the front line, would you use it as a single agent? I think we're going to have to figure that out. So there's a lot of big questions on the table right now in terms of sequencing, and they're going to get more complicated potentially because we have 3 frontline ovarian cancer trials resulting, I think this year, should be this year or early next year, all of which include BRCA patients, but all of which include non-BRCA patients, importantly, as key primary endpoint populations. So if those are positive, then potentially everybody's getting a PARP in the front line, and then what do you do? So I think it's about to get, my prediction is that those are positive. I don't know. I really don't, but I think it's about to get complicated.